keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
Hi, welcome to another round of the dynamic editorial for the JACC Cardiovascular Imaging. My name is Dr. Chandrasekhar and I'm one of the associate editors for the journal. My guest here is Dr. Albert Lardo, Associate Professor of Medicine and Biomedical Engineering at the Johns Hopkins Institute. And we're going to talk about a very exciting paper that's coming in a near future issue of the JACC Cardiovascular Imaging. Welcome, Dr. Lardo.
Thank you very much.
Okay. Tell us a little about this paper and what does it address and how does it fill a gap of something that we already don't know?
Sure. So we started this study about 3 years ago. We first demonstrated the ability to do viability imaging by CT. The radiation dose was quite high, though. So we were interested in the ability to do both CTA and viability imaging, but with a low-dose protocol. So typically these protocols are done by retrospective acquisitions, in which the X-ray beam is on for multiple heartbeats. And then from those heartbeats, we can then reconstruct whatever phase of the cardiac cycle we like. For this particular approach, we decided to use a prospective approach. And this is equivalent to what has been done on the CTA side now with a couple of newer protocols. But what we wanted to demonstrate was that we could reduce the radiation dose by an order of magnitude using a prospective gated approach without decreasing too much the tube settings of current and voltage, which can lead to poor signal-to-noise ratio. So what we're hoping from this study and what we've implemented now at Hopkins is the ability to do viability imaging, an additional scan on top of the CTA with a very low radiation dose.
Yeah, that's a big advantage. There's so much care about radiation right now, and so anything that reduces radiation and gives us valuable information is pretty good. So you routinely use this in your protocol now for patients?
Yes. So we have since the time of that paper have now upgraded our scanner to a 320 detector scanner from the 64. And what we do now is a very comprehensive workup by CT that includes adenosine stress perfusion imaging, followed by rest CTA, and then the final acquisition is after 5 minutes after the last contrast injection is this delayed enhanced CT study that's done in a prospective fashion. So we use it as part of at the end as a total workup from perfusion, CTA, and anatomy and atherosclerosis imaging, and then follow it up with viability imaging in a prospective fashion. So we're able to do all of those acquisitions in about the radiation dose and contrast dose that's currently used for retrospective 64-slice CTA studies. So it's quite impressive that we're able to get so much more information for the same radiation and contrast budget.
In this animal model that you used, it's trying to kind of put on a scientific footing what we probably already do in practice, try to reduce radiation as much. You had an ischemia reperfusion model. Would it make a difference if you had a non-reperfused myocardium like the patients we see sometimes?
Yeah, it's a terrific question. I think it would indeed, because with our particular model, when we reperfuse at 90 minutes, we're actually generating some reperfusion injury, and we're able to image that very clearly as no reflow or microvascular obstruction. And I think that in the non-reperfused ischemic model, that we would see something quite a bit different, actually. That is, a void of contrast in that particular bed of the myocardium until we've had sufficient diffusion of the iodine tracer into the cells. And the enhancement mechanism acutely is actually very different than that chronically. So I think that the enhancement patterns would be very different, and certainly the perfusion component of the study would be different.
The other question is you had to use a dye which is probably a little different than what you would use in the patient population. Do you modify it for what we use in?
No, actually, the contrast agent we use is what we use clinically. And the total radiation, the total contrast dose that we used was probably that of about equivalent to a dose and a half for a human equivalent dose. So we used a little bit more iodine in this particular study because the hypothesis was really that we can get clinically relevant quality using an order of magnitude less radiation. So we wanted to make sure that we actually accomplished a pacification of the infarct.
And you think this is going to be a commonly done thing in future, where you would get an extra scan to look at viability since the information is there?
Yeah, absolutely. And that's what we're very excited about. And even in this, the most recent session of the American Heart Association, we saw such an increase since our original description of the viability studies, a huge increase in the number of centers now performing these viability delayed studies in their patient population. So we're convinced now, I think, that the ability to reduce the radiation as much as we have for this particular late scan will only help encourage people to get this information, especially patients with devices that cannot undergo MRI.
So there you go. That puts it into perspective. Wherever we can reduce radiation and gain information, that's always a highly desirable thing. And Dr. Lardo's paper provides a scientific rationale of what we are already doing and will be doing more in future. Thank you, Dr. Lardo. That was very useful. And thank you for listening, and I hope you found it useful.
Keeping an eye on imaging.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.